This lecture will be about Hodgkin's lymphoma. So to begin with, what is a lymphoma? A lymphoma is a neoplasm of white cells, mostly the lymphocytes. And these lymphocytes, they will present as tissue masses, usually in the lymph nodes or other lymphatic tissues or in the secondary lymphoid tissue. And that is what we call as a lymphoma. Now, the lymphoma is broadly classified into Hodgkin's lymphoma and non-Hodgkin's lymphoma. Now, how do we differentiate between these two? So they are differentiated by 4 features. So there are 4 features which differentiate between a Hodgkin's lymphoma and a non-Hodgkin's lymphoma. So let's speak about the features of Hodgkin's lymphoma. First and foremost, the Hodgkin's lymphoma has a really classic presentation with the lymph node lymphadenopathy localized to a single group. So localized to a single node or group. Whereas in non-Hodgkin's lymphoma, multiple peripheral lymph nodes may be involved. Secondly, the spread of disease occurs in a contagious manner in Hodgkin's lymphoma. Whereas in a non-Hodgkin's lymphoma, the spread can occur through any way. There is by contagiosity, what we mean is that first a lymph node is involved, then the closest lymph node is then involved, and then the third lymph node is involved. So there's a progression. That's what we mean by contagiosity. That is the closest area or the closest draining lymph nodes are involved. So there is a class. This gives Hodgkin's lymphoma a really classic presentation, a stereotypic presentation. Then the third feature will be that the extranodal involvement is usually rare. It is usually seen in the stage 4 of the disease. We'll be discussing about staging of Hodgkin's lymphoma in the end, compared to the non-Hodgkin's lymphoma where the extranodal involvement is really common. And finally, the mesenteric group of lymph nodes and the Valdez ring. These two groups of lymphoid tissue are rarely involved. So they are rarely involved. Not involved is not the correct statement. They are rarely involved. That's how we differentiate a Hodgkin's lymphoma from non-Hodgkin's lymphoma. 2 points that we need to remember is they have a classic presentation. And the additional point is about their cell type, that is, which is the neoplastic cell. So the neoplastic cell in Hodgkin's lymphoma, they are called as the Reed-Steinberg cells. So these are our Reed-Steinberg cells. And actually they are not the majority cells. When we look through the biopsy, they are minority. They constitute only 1 to 3% of the total cells. And when we discuss about pathogenesis, we'll find out why they constitute 1 to 3%. And what about the remaining 90%? What are they made up of? We'll discuss about that in pathogenesis. So what are these Reed-Steinberg cells and where do they originate from? So the Reed-Steinberg cells, they originate from either the germinal center B cell, or the post-germinal center B cell. So these two cells will give rise to, or they will develop into, Reed-Steinberg cell. Now, how do we describe an RS cell? We'll call it an RS cell. So as we know, they are giant cells. That is the first point. They are giant cells. Secondly, they have an eosinophilic cytoplasm. The cytoplasm is eosinophilic. So first point about their nucleus is they have 2 nuclei. They are binucleated and they have an eosinophilic nucleolus. So these are the 2 points that we need to know about Reed-Steinberg cells. Now, what about the age? Usually, Hodgkin's lymphoma affects the young adults. So the age group is young adults, and the most common age group that is affected is said to be 32 years. According to Robbins, 32 years is the most common age group which is affected. Now let's move into the part of pathogenesis. So in pathogenesis, we'll discuss why we have a minority of RS cells and a majority of non-reactive lymphocytes. So what happens is that there are 3 factors which contribute to the development of Hodgkin's lymphoma. The first one is the EBV, that is Epstein-Barr virus infection. So infected Epstein-Barr virus, we know that they have a latent membrane protein, right? And this latent membrane protein will activate the nuclear transcription factor. So that is the most important factor which is involved, nuclear transcription factor. This is the most important factor which will lead to the development of RS cells from the germinal or post-germinal B cell. That's our first factor. And then there are genetic factors which are contributing to it. And then there is autoimmunity. So people with autoimmune disorders have a higher possibility of getting Hodgkin's lymphoma. And how do they activate or how do they cause? Well, they all go through this common pathway, that is activation of nuclear transcription factor. Now, what does the nuclear transcription factor do? Well, it converts the B cell. So this is our B cell, and it converts the germinal or post-germinal B cell into the Reed-Steinberg cells. So these are our Reed-Steinberg cells, the giant cells with two nucleus, eosinophilic nucleolus and an eosinophilic cytoplasm. Now, these germinal B cells or post-germinal B cells, they usually will undergo apoptosis if they do not develop into the plasma cells. When the nuclear transcription factor is activated, they will evade apoptosis, and then they will develop into the RS cells. These are our RS cells, and these are our germinal or post-germinal B cells. Now what happens is that this RS cell will secrete several cytokines, and that is how Hodgkin's lymphoma develops. So it will secrete several cytokines. Let's take 3 of them. It will secrete IL-6, interleukin 6, and interleukin 6 will activate the plasma cells. So these are our plasma cells. And what do plasma cells do? They will secrete immunoglobulins. So Igs will be secreted, and the RSNs will secrete tumor growth factor beta that will activate the fibroblast. So there will be deposition of collagen, and then these RSNs will secrete other interleukins that will activate the reactive T lymphocytes. So we have the T cells, here we have the plasma cells, here we have the fibroblast. They could also activate the eosinophils. So these are the eosinophil, and the eosinophils are activated by the secretion of interleukin 5. So the RS cells secrete a large number of cytokines, and these reactive, which will activate the reactive white cells and fibroblasts, including the plasma cells, T cells, and eosinophils, and they will form what we see in the histopathologic section. So these cells will constitute more than 97% of cells in Hodgkin's lymphoma. And in addition, what happens is that the eosinophils and the reactive T cells, what they'll do is they will activate the CD40 and CD30 receptors. So there is a CD30 receptor and CD40 receptor on the RS cell. The T cells will activate the CD40 receptor, the eosinophil will activate the CD30 receptors. And when these receptors are activated, again the nuclear transcription factor is activated and the cycle continues. So that's the pathogenesis. Now let's move into the classification. So classification of Hodgkin's lymphoma is into 2 types. One is the classical Hodgkin's lymphoma, classical HL, and the other one is the nodular lymphocyte predominant HL. So nodular lymphocyte predominant HL. So we will discuss about each of this. Now what is the classification based on? The classification is based on the type of RS cell. Actually, RS cell is not just a single type. There are different types of RS cell, which we'll discuss next. But before that, the classical Hodgkin's lymphoma is again of 4 types. So there are 4 types. The first one is the nodular sclerosis classical Hodgkin's lymphoma, CHL. That is NSCHL. Then there is mixed cellularity. These terms might seem to be, confusing and all, but actually once we learn about the individual, if we look at each term, we'll understand what they mean. The third type is lymphocyte rich, CHL, and then there is a lymphocyte depleted, CHL. So these are the 4 types of classical Hodgkin's lymphoma, and the nodular lymphocyte predominant is actually just a single type. It does not have further subdivisions. Now let's move into the types of Reed-Steinberg cell. So we actually have 6 types of cells. The cells do not appear same. There could be 6 different varieties. So first one is what we had said. This is our classic RS cell. This is the classic Reed-Steinberg cell. We have already discussed about it. And the second type is the mononuclear cell variant. As the term suggests, there is only a single large nucleus, and inside this nucleus there is a nucleolus, as an inclusion type nucleolus. Now this can be seen in any type of CHL. So in all 4 types of classical Hodgkin's lymphoma, all of these 4 types, you can get a mononuclear variant. Similarly, classic RSL can also be seen in these 4 types. Now the third one is the lacunar variant. The lacunar variant actually means here the cytoplasm, if we look at, the cytoplasm is actually disrupted and it is clear. We call it the water clear cytoplasm. So the cytoplasm is clear and it appears like a lacunae, and the eosinophilic nucleoli is present, and there is a multi-lobed nucleus. There are multi-lobed nuclei. These are the features of lacunar variant. Now coming to the fourth type, that is the mummified variant. The mummified variant. The thing is, the RS cells do not undergo the normal apoptosis. A mummified variant is an RS cell that is undergoing apoptosis. So the nucleus is, it will have a pycnotic nuclei. This actually does not have any value, any diagnostic value. It just indicates Hodgkin's lymphoma. But if you see mummified variant, we cannot say that it is necessarily Hodgkin's lymphoma. It's just a strong indicator, that's all. And then we have the anaplastic variant. Anaplastic or pleomorphic type, and this is found in the lymphocyte depleted CHL. So they have large number of hyperchromatic nuclei. That's a feature, hyperchromatic nuclei. And as we know, always anaplasia is associated with a poor prognosis, right? So whenever we see an anaplastic variant, the Hodgkin's lymphoma has a poor prognosis. And finally, the sixth type is our lymphocyte predominant. Lymphocyte predominant RSL. As the name suggests, we have said here nodular lymphocyte predominant HL. So this will be found in the nodular lymphocyte predominant Hodgkin's lymphoma. Now here there is a pale cytoplasm, and the characteristic feature here is it has a popcorn nucleus. The nucleus is the shape of popcorn. So popcorn nucleus is the characteristic feature. So the differentiation of Hodgkin's lymphoma is into a classic, is differentiated into the classic RS cell and the lymphocyte predominant RS cell. These are the two main types, and then we have the other subtypes which include the mononuclear, where only a single nucleus is present, then lacunar, where it contains a cytoplasm is clear and has is in the form of a lacunae. Then we have the anaplastic variant, which we know will have a poor prognosis, and then the mummified variant, that is an RS cell that is trying to undergo apoptosis. So those are the types of Reed-Steinberg cells. Now let's discuss about each type, each subtype. So we'll discuss under the following headings. First one is the nodular sclerosis CHL. First one is the number of cases. How common is this variant? So this is NS-CHL, right? This is actually the most common type, and it accounts to about 70% of the total cases. So 70% of all Hodgkin's lymphoma is a nodular sclerosis variety. And the sex and age, it usually affects young adults, that is 20 to 30. We have said that the mean age is 32, and both sexes are equally involved. So a 20 to 30-year-old male or female is more susceptible. Then about association with Epstein-Barr virus infection, it is not much associated. So not is not the correct term. We could say it is rarely associated. Then we'll discuss about the immunophenotype. So the RS cells will be CD15 and CD30 positive. And usually they will be negative for EBV. As we have said, they are rarely associated. And in microscopy, we'll discuss about the type of RS cell which is seen. Usually the lacunar variety is seen. So the lacunar variety of RS cell is seen. So this is our lacunar variety. So we can say that they are found in nodular sclerosis CHL. And then about the background. So we have said about the reactive white cells that are present, right? Now the background actually consists of these two terms. That is how we get the definition. That is nodules and sclerosis. Sclerosis usually means collagen, right? So there will be broad collagen bands that will divide the structure into nodules. So that is how we get the term nodular sclerosis. So and the prognosis is usually, it has an excellent prognosis. It has an excellent prognosis. Now how does it look? There will be several nodules, and in between these nodules there will be collagen fibers. So collagen sclerotic bands will be present that will divide into nodules. And then inside that we have our classic, our lacunar variant. So there will be a lacunar variant of Reed-Steinberg cells. And this lacunar variant will be surrounded by reactive lymphocytes. To mark, we'll have the lacunar variety, lacunar RS, the reactive WBCs, collagen band. These are the three features of nodular sclerosis CHL. Now let's move into the mixed cellularity. Again, we'll discuss under the same heading. The mixed cellularity, we said that the other NS-CHL occurred for 70%. Mixed cellularity will account for 20 to 25%, mostly affecting the males. And it has a strong association with EBV. So there is a strong association with EBV. And the immunophenotype, again, the classic cells will be CD15, CD30 positive. and they are strongly associated with EBV as well. Now, what about the type of R cells? So all types of RS cells are usually present. That is a point to note. And the background will be, that is where the term mixed cellularity comes from. So now we understand that the classification is actually based his own histology, right? So there will be mixed cells of lymphocytes, eosinophils, plasma cells, macrophages, everything will be present. Plasma cells, macrophages, all of these will be present. And the prognosis is actually good, even though it is advanced in staging, not as good as an SCHL, but comparatively, compared to the other types, it still has a better prognosis. So how will we look? We know that there will be different types of Reed-Steinberg cells, mainly the classic cell. There won't be the nodular type. And then we'll have plasma cells. We'll have the, on a background, we'll have the reactive lymphocytes. We'll also have eosinophils in the background. So that's about mixed cellularity CHL. Next, we'll speak about lymphocyte-rich CHL. It is rare, about 5%. Coming to the sex, it is associated with sex and age, elderly patients of both sexes. Lymphocyte-rich is associated with elderly people. Now, association with EBV is usually rare. So there is rarely associated with EBV. Now coming to the immunophenotype, as I said, it's a classic type. So all classic types will be CD15 and CD30 positive. That's what we need to understand by now. Coming to the type of Reed-Steinberg cell. So it will contain our classic RS cell. And within the background, there will be several lymphocytes. So that is why they are called as the lymphocyte-rich CHLs. Now the prognosis is usually good to excellent, and not just type of the RS cell, there is also the mononuclear variant may also be present. Now these two types of cells are present. So how will they look? So we have our classic RS cell, and then we have our mononuclear variant RS cell, and then we'll have several, around 90%, 90 to 95% will be covered with lymphocytes. Now moving on to the fourth type, there is a lymphocyte depleted CHL. It is present, it is the rarest thing, that is what we need to know. It is a very rare form, and it usually has a poor prognosis, and it affects the elderly patients, both male and female, the HIV patients, and immunocompromised individuals. And it has the strongest association with EBV. Around 90% there is always an infection by EBV. And the immunophenotype, as we have said, it will be CD15 positive, CD30 positive, and it will be EBV positive in 90% of the cases. Now, as I've said, there is a poor prognosis. Whenever we say poor, anaplasia should come into our mind. So anaplastic RSL will be the most predominant one. And there will be very few lymphocytes. Compared to the other type, here the anaplastic cell is predominant, whereas the RS cell is predominant, whereas the lymphocyte cell is actually less. We have said that RS cell is usually just 1 to 3%. But in lymphocyte depleted CHL, that is LDCHL, the anaplastic cell count is really high, and the prognosis, as we have said, it has the poorest prognosis of all Hodgkin's lymphoma. Several anaplastic RS cells, and these cells will be surrounded by very few lymphocytes, and in between them there will be fibrous bands. There will be loose collagen bands. This will be the histologic feature of lymphocyte depleted CHL. Now finally moving on to our nodular lymphocyte predominant Hodgkin's lymphoma. The first thing about cases, it is rare. It occurs to 5% of cases, mostly affecting the males, and it is not associated with Epstein-Barr virus. And for the nodular lymphocyte, it is negative for CD15 and CD30. We said that the classic cell is positive, whereas the RS cell, the lymphocyte predominant RS cell, is negative for CD15 and CD30, whereas it is positive for CD20 and CD45. So that's about it. And now coming to the type of RS cell, we have said that it is the lymphocyte predominant RS cell which will be present. And the background, so it will have a popcorn nucleus. That is the main feature that we need to remember. There will be a popcorn nuclei. And in the background, there will be other cells. So there will be lymphocytes and macrophages. The prognosis is usually excellent. So that's in a nutshell about the 5 types. Now coming to some peculiar features about each of the different types. Coming to the mixed cellular type, there may be systemic features such as fever and night sweats. And it is also associated with advanced stage. So stage 3 or stage 4, we'll discuss staging next of classic Hodgkin's lymphoma. Then coming to the lymphocyte rich type, it usually involves the peripheral lymph nodes. Peripheral lymph nodes are involved. And the lymphocyte depleted, as we have said, it has a poor prognosis. And this is the one which will involve the bone marrow and the retroperitoneal lymph nodes. Retroperitoneal lymph nodes. Coming to the lymphocyte, nodular lymphocyte predominant Hodgkin's lymphoma. The peculiar feature is that it involves the axillary or cervical lymph nodes. And the nodular sclerosis, it will involve the mediastinal lymph nodes. So these are some of the features about, that's all, everything about Hodgkin's lymphoma. Finally, moving on to our last section, which is the clinical features and about the staging. So the disease has a classic presentation. So first there will be a lymph node involvement, okay, and then there will be a lymphadenopathy. The lymph node involvement will be in the form of lymphadenopathy. And then what happens is that the disease will then involve the contiguous lymph nodes, the nearby lymph nodes. The disease will spread as it progresses. And then there will be splenic involvement. The spleen will be involved in the third stage. And then the liver will be involved. So there will be hepatic lymph node involvement. And finally, in the last stage, the bone marrow will be involved. Bone marrow and the extranodal involvement. Extranodal involvement is very rare, and that will be seen in the final stage. So in our staging is what we use for staging of the lymphoma. The lymph node involvement is usually in stage 1 and 2. Stage 1 and 2. And the splenic liver involvement, they will include the stage 3 and 4. We'll discuss in detail. There is more to it. Roughly, they will include the stage 3, not stage 3 and 4, stage 3. And the extranodal involvement is said to be stage 4 and has a poor prognosis. So there are 4 stages, as we have said now. The first one is stage 1, stage 2, stage 3, and stage 4. So what is stage 1? Stage 1 means a single lymph node is involved. Stage 2 means 2 or more lymph nodes on same side of diaphragm. So 2 or more lymph node on same side of diaphragm. That is important differentiation between stage 2 and stage 3. Same side of diaphragm. What about stage 3? Stage 3 means 2 or more lymph nodes are affected, but on opposite side or both sides of diaphragm. So the lymph nodes on both sides of diaphragm are involved. And stage 4 means there is an extra nodal involvement. And the stage 3, actually it is again differentiated into a 3-1 and 3-2. 3-1 means whether the spleen, so we are discussing about the splenic and liver involvement. So whether the spleen, hilar or portal lymph nodes are involved or not. That is what 3-1 classification is based upon. Whereas the 3-2 classification means a further involvement. So it means a further progression involving the mesenteric. We said in the beginning that mesenteric lymph nodes are rarely involved. That's only involved in advanced stages. So that is mesenteric, iliac or para-aortic lymph nodes. To understand, the stage 1 means a single lymph node. Stage 2, 2 or more lymph nodes on same side of diaphragm. Stage 3 means 2 or more lymph node on opposite both sides of diaphragm, with 3-1 indicating involvement of spleen or liver. 3-2 means a further progression into the mesentery. And stage 4 is extranodal involvement. So that's all about Hodgkin's lymphoma.